Hey, fifth-year medics. Let's jump right into this high-yield explainer on Parkinson's disease pharmacology. If you're gearing up for board exams or honestly just want to absolutely nail your neuro and pharma rotations, you're in the right spot. I'll be your tutor today, and we're going to distill Professor Enza Palazzo's lecture into the absolute must-know, rock-solid concepts. Real quick, here's our roadmap for today. We're hitting pathophysiology, treatment rationale, levodopa and its adjuncts, adverse effects, overarching therapeutic strategies, and finally, my favorite, a rapid-fire list of key exam pearls.
Section 1, Pathophysiology of Parkinson's disease.
Okay, before we even think about writing a prescription, we've got to understand the physical break in the brain. Parkinson's is this idiopathic neurodegenerative disorder, and the whole thing is defined by a progressive loss of dopaminergic neurons. Specifically, we're talking about the pars compacta of the substantia nigra. If you compare it to a healthy brain, you can literally see the loss of that dark pigment. It just fades away.
But here's what's wild. A normal aging brain loses some of these neurons, sure, but Parkinson's? The clinical symptoms, the uncontrolled resting tremors, the stiff muscles, the bradykinesia where they just can't start a movement, those don't actually show up until dopamine levels crash below a critical 10% threshold. Less than 10% remaining. That is a massive, massive deficit before the alarm bells even ring.
Moving on to Section 2, Rationale for Dopamine Replacement. So, knowing we have this extreme neurotransmitter deficit, the obvious question is, why can't we just give the patient a dopamine pill, right? Like, why not just replace it directly and call it a day? Well, the blood-brain barrier is basically a giant bouncer, and dopamine simply cannot get in. It won't cross. So we have to hack the brain's natural synthesis pathway. Normally, the amino acid tyrosine crosses the barrier, gets converted to levodopa, or L-dopa, by tyrosine hydroxylase, and then L-dopa becomes dopamine via dopa decarboxylase. Because plain dopamine is a no-go, our primary pharmacological strategy is giving that precursor, L-dopa. L-dopa actually has a VIP pass. It easily crosses the blood-brain barrier using the aromatic amino acid transporter.
Section 3, Levodopa, carbidopa, and adjuncts. Now, executing that L-dopa strategy is tricky because we really have to protect it on its journey. If you give a patient L-dopa all by itself, peripheral enzymes will totally chew it up before it ever reaches the brain. You're left with maybe 1 to 3% for the central nervous system. Not good. So we deploy peripheral bodyguards. We almost always combine levodopa with carbidopa in a 1 to 4 ratio. Carbidopa acts as a shield, blocking peripheral L-dopa decarboxylase. We can also throw in COMT inhibitors, like enacaprone. These block a whole other peripheral degradation pathway that converts L-dopa into useless metabolites. By blocking these peripheral enzymes, we massively boost the amount of levodopa that actually makes it to the brain. And as a huge bonus, we cut down on nasty peripheral side effects like severe nausea. Alternatively, we can bypass L-dopa altogether and just stimulate the dopamine receptors directly using dopamine agonists. Nowadays, we rely on non-ergo derivatives. You've got pramipexole, which has a super high affinity for D3 receptors and is great for advanced disease. Then there's ropinirole, often used as monotherapy for milder cases. Oh, and rotagotine is brilliant. It's a transdermal patch, so it keeps plasma concentrations incredibly stable. Now, for absolute emergencies, like those severe off episodes where a patient is literally frozen in place, we use apomorphine. It antagonizes D1 and D2 receptors and is given subcutaneously. But here's a huge exam pearl. It causes violent vomiting. You absolutely must co-administer it with an antiemetic like domperidone. Rounding out our adjunct therapies, we've got 2 incredibly unique players. First up, amantadine. This is a polymodal antiviral drug that actually increases dopamine release, but its claim to fame for your board exams is that it acts as a non-competitive antagonist of NMDA receptors. That makes it the absolute go-to for treating dyskinesia. Next, we have our MAO-B inhibitors like selegiline. Unlike MAO-A, MAO-B is highly concentrated in the striatum. By selectively inhibiting it there, we basically trap dopamine in the brain, completely stopping its breakdown and really prolonging that therapeutic effect. Section 4, Adverse Effects and Complications. You guys, examiners absolutely love testing you on the timeline of these side effects. You have to mentally divide them into acute versus late. Acute effects pop up early on. Peripherally, you're looking at nausea, vomiting, and really dangerous hypotension. Centrally, that sudden surge of dopamine can trigger hallucinations, delirium, and a total loss of impulse control. Usually you just lower the dose to manage these. But the late chronic effects, man, those are what make long-term management a nightmare.
After about 10 years on levodopa, 80% of patients develop dyskinesia, these debilitating, abnormal, writhing muscle movements. They also get hit with severe on-off motor fluctuations.
This wearing off curve is the perfect visualization of those motor fluctuations. Over time, as treatment drags on, the therapeutic window gets narrower and narrower. You literally watch the patient bounce from perfectly fine symptom control straight into severe akinesia the second the drug concentration drops. That's the classic wearing off phenomenon. And if you try to fix that akinesia by bumping up the dose, boom, they immediately cross the upper threshold right into the severe dyskinesia danger zone. It's an incredibly tight tightrope walk.
Before we move on from adverse effects, please lock this into your memory. If you get a test question or a clinical vignette and they describe a Parkinson's patient with a painless, net-like purplish skin discoloration, usually on their legs, that is livedo reticularis. The second you read that, you know without a doubt the patient is taking amantadine. Write that down, it's a guaranteed point on test day.
Section 5. Therapeutic strategies and combinations. Okay, let's put the puzzle together. How does all this pharmacology translate to a real patient's lifetime treatment plan? We know levodopa is our heavy hitter, but its magic starts to fade after 3 to 4 years, and it eventually triggers that awful late-stage dyskinesia. So in the early stages, with mild symptoms, we actually hold it back. We start with dopamine agonist monotherapy. It gives us nice, continuous, physiological stimulation and buys us a lot of time. As the disease advances, we inevitably have to bring in the levodopa and carbidopa combo. And finally, in the later fluctuating stages, we're throwing everything at it, adding COMT or MAOB inhibitors to smooth out those wearing off curves, or even using a portable pump for continuous duodenal gel infusions just to keep plasma levels completely flat.
Section 6. High-yield key exam pearls. We are at the finish line. If you zoned out for anything else, tune in right now. Memorize these rapid-fire pearls for your exams. Pearl 1. L-dopa is basically useless without its bodyguard. Always, always give it with carbidopa. Pearl 2. Patient on long-term levodopa gets abnormal writhing movements. Amantadine is your savior because of its NMDA antagonism. Pearl 3. Patient is acutely frozen in a severe off episode. Hit them with sub-Q apomorphine. Pearl 4. A patient on a Parkinson's regimen suddenly can't sleep at all. Check if they're on salicyline. It's an MAOB inhibitor that literally metabolizes into amphetamines.
Keep them coming. Pearl 5. Enzyme selectivity is dose-dependent. High-dose selegiline crosses over and blocks MAOA. If that patient eats aged cheese or drinks red wine, the tyramine buildup will cause a massive, life-threatening hypertensive crisis. Pearl 6. Entacapon works strictly in the periphery to block COMT. Pearl 7. We totally avoid ergot dopamine agonists like bromocriptine these days because they wreck heart valves. And Pearl 8. Pramipexole isn't just a D3 agonist. There's strong evidence suggesting it's actually neuroprotective. To wrap up this explainer, I'll leave you with one final thought. What is our single most powerful therapeutic weapon, yet the exact one we intentionally hold back early in the disease to avoid devastating long-term dyskinesias? It's levodopa. Understanding that delicate, high-stakes balance, maximizing dopamine while dodging those long-term complications is the whole secret to mastering Parkinson's pharmacology. Internalize these pathways and you are going to absolutely crush your boards. Keep grinding, and I'll see you in the next one.